I'm Sunanto from University of Pelita Harapan in Indonesia. Thank you for the invitation. I will present a case that I hope that it will provide a learning perspective in complex left-main PCI. So this is the case, male, 69 years old. Actually, he was referred from other hospital with STEMI, inferior, and RV infarction. He arrived at our hospital at about 5 p.m. At that time, there was no complaint, no chest pain. The chest pain was 5 days ago. The blood pressure is okay. Heart rate was 80. Oxygen saturation is okay. The cardiac troponin was high. And but 4 hours later, he developed a severe chest pain with dyspnea on effort and sweating. Blood pressure was dropped to 90 and heart rate increased. So the hemodynamic was down. So we did an urgent echo and then PCI. This is the ECG. We can saw the QR in inferior lead with ST elevation, but there is no apparent Q wave at the anterior and slight ST depression and T inverted at the P4 to P6. And I did the echo shown here. So not only that the inferior wall was akinetic, but the anterior wall was also akinetic. So, and apparently there was a scar at the anterior wall up to the apical. And this is the angiography. So at that evening, I did the angiography. So we directly sent it to cath lab. And showing here the occluded of the RCA, but also severe disease from left main to LAD, long lesion. The RCX looks not severely diseased, and we can show here that there was a collateral to the right artery, and seems that the right artery quite dominant. So the question to myself at that time, what should I do to save this patient? This patient already in the shock hemodynamic. Should I send it for KBITS or should I do PCI? Which kind of strategy should I do? Should I PCI the right first and then the left, or should I do the left first then the right? I believe that the left coronary artery caused a severe ischemic and hemodynamic turbulence. At that time, I decided to do PCI because I think the KBITS cannot done soon. And I really wish that I had IVUS ready at that time, but we don't have that at that time. So I did the PCI to the right. It's quite a straightforward procedure with a one desk implanted. There was a mild quite spasm at the proximal of the RCA, but can be resolved with nitrate intracoronary. Then I proceed to the left. So this is the angiography of the left coronary artery. I try to wiring with the cyan blue, but can't pass through. I put the cyan blue to the septal, and then I use another wire, cyan black, which is more hydrophilic, and it can pass through. Then I predilate the lesion from a small balloon up and upsize to a bigger balloon. So every time I inflate the balloon, the pressure dropped down and the patient was getting restless. So every time we occlude the coronary, we have to push a little bit noradrenaline to increase the blood pressure. At that time, I think I have to open the tightest part of the left coronary artery as fast as possible. So my target of this lesion is the mid segment of the left LED and then the proximal to the left main lesion. And I think I have to do it quite fast. And fortunately, I think there's no severe calcification. So I think I can do it with a two-stent crossover strategy to the left main. So I put a stent, the first stent to the mid of LED with a DES 2.75. And then I saw that the proximal part of the LED up to left main is not optimally prepared. So I have to do another pre-dilatation with bigger balloon with NC up to 20 ATM. I hope that it can a little bit modify the proximal lesion. And then I put a stent, a crossover from proximal part of the LED to up to left main, the mid left main, with a 3.5 DES, 12 ATM. And then I do a post-dilatation at the proximal part of the LED with balloon NC 3.5 and port with 4O at the left main up to 20 ATM. And I think, I hope I can achieve quite good expansion of the stent. Or unfortunately, I really hope that I have IFUS at that time, but we don't have it. And also the patient at the end of the procedure got increasingly shortness of breath, so he have to be put in a sitting position, otherwise he will get intubation, which we avoided. After PCI, soon after PCI, the patient have a lung edema but can be well treated with a position diuretic and non-invasive ventilation support. And the low blood pressure was supported with an inotropic and vasopressor. And at day 1 to day 3, the patient getting better, the hemodynamic getting better, the inotropic and vasopressor could be tapered off, and the patient start to mobilize and sitting around the bed. There was some pleural effusion was tapped, and the pulmonologist suspected of tuberculosis, but I think there is a role from the infarction. She was given with potent antiplatelet and anticoagulant as well. Was injected subcutaneously. At day 4, the patient was planned to move to the ward in the morning, but while sitting, without any prior chest pain, without any prior dyspnea, he suddenly collapsed and there occurred the VTVF, and unfortunately, the CPR cannot recover the patient and patient declared dead. So the learning points, at least for myself, there is a situation that we cannot avoid a complex and high-risk left main PCI to save patients' life. In the complex and high-risk left main PCI, mechanical circulation support might be careful, but it needs a system to fast apply in the left main PCI. And every time I have to evaluate myself after the angiography whether I can do it safely and completely every time I stop myself. So, and we have to be prepared anytime, and IFUS is very important for left main and long lesions for optimization. Pharmacological and hemodynamic support is very helpful with appropriate timing administration during the procedure as well. And I think it's also very important to brief the personal care lab about the critical situation that we are going to face. The cause of death in this patient is still hypothetical. It can be related to the scar-related arrhythmia, or it can maybe also related of a stent thrombosis. Thank you.
Okay, Dr. Santos, for